Hello, this is Luke Thomas again, and welcome to this new podcast dedicated to nail dermoscopy. You will see 5 nail dermoscopy cases with comments. You will have first the clinical images and then some information if needed. You will have some time to think about the dermoscopy image and then we will comment the case. Let's start with the case number 1. It's a male patient, 34-year-old, and the lesion has been present on his left thumb for at least 1 year. He was concerned because of the pigmentation observed on the distal part of the nail plate. You have few seconds to think about the dermoscopic findings. Let's comment this case. We observed on the distal part of the nail plate splinter hemorrhages, bleeding underneath the nail plate. We observe a longitudinal process that is pink or reddish colored. We call this longitudinal erythronychia. The lunula has a strange shape, is somewhat triangular shaped with some disruption of the edge of the lunula. And looking at the distal edge of the nail plate, the free edge, we can see this localized subungual hyperkeratosis that is located just in front of the longitudinal process. And looking carefully at the lunula, it's possible to identify the precise location of the nail matrix tumor. On the basis of these dermoscopical observation, we propose a diagnosis of an epithelial tumor of the nail matrix. Could be Onychomatricoma, squamous cell carcinoma, onychopapilloma, but bleeding was more in favor of a malignant disease. And finally, the diagnosis was Bowen's disease. This disease was confirmed by histopathology, and the patient was treated surgically and is fine after 2 years. Let's move to case number 2. It's a male patient. He's 7-year-old at the time we took these photos, but the lesion was present since birth and no change was observed after the age of 1. Between birth and the age of 1, the lesion progressively enlarged, but is now stable for many years. So this is the clinical image, and you can discover melanonychia striata that involves most of the nail plate surface. This is dermoscopy, and you have few seconds to think about it. Let's comment this case. I must start by saying that it is a very difficult case. We can see that the color of the background is brown, indicating melanocytic hyperplasia in the nail matrix. And the pattern of the longitudinal lines is very irregular in color, spacing, and thickness. In an adult, this pattern would be in favor of a melanoma, but knowing that the lesion was present since birth led us to think of a congenital nevus of the nail unit. We made this diagnosis of congenital nevus of the nail matrix, and the patient has been followed for 5 years. And now after 5 years, the lesion was stable and is starting to progressively vanish. So we are very confident in the diagnosis of a congenital nevus of the nail matrix with regressive evolution. Diagnosing these congenital nevi of the nail unit is very difficult. For that reason, the IDS set an international register of these congenital nevi of the nail unit, and if you have some of these cases among your patients, please go to the website of the IDS to declare these cases and to have them included in that study. Let's move to case number 3. It's a female patient, 47-year-old. The lesion is present on left big toe. It's been present for a few weeks, and this is dermoscopy. Let's comment this case. We see that the proximal edge of the pigmentation is round-shaped, and we'll see that the distal edge is somewhat filamentous. But above all, we see that the lesion starts in the lateral nail fold and not in the proximal nail fold. We know that all dangerous pigmentation of the nail unit start from the proximal nail fold, and that is significantly the case of melanoma. Having a lesion starting from the lateral nail fold is somewhat a good symptom. We propose the diagnosis of subungual hemorrhage, and we propose to this patient to be followed. And these are the follow-up images after 6 months, and you see that the pigmentation moved towards the distal edge of the nail plate, and that nothing was hidden beneath and underneath the bleeding and the dark lesion. So this distal migration of the pigmentation is a good sign. Let's move to case number 4. It's a male patient, 57-year-old. The lesion is located on the first right toe, big toe. And you can see that this patient is dark-skinned and that the second toe is longer than the first one. We call that shape of the foot a Greek foot. And this indicates that in tight shoes, the second toe will push on the table of the first one. This is a dermoscopic image, and you have a few seconds to think about it. Let's comment this case. It's an easy case. You have a gray pigmentation of the band, and for that reason, we think that there is no significant melanocytic hyperplasia in the nail matrix. These features are in favor of a lentigo, an ethnic type pigmentation, trauma-induced pigmentation, or drug-induced pigmentation. In that case, we made the diagnosis of a lentigo of the nail matrix, maybe also due to the dark skin of the patient and to repetitive trauma of the second toe over the first one. Let's move now to our last case, case number 5. It's a male patient, 42-year-old, and this is the lesion. It's not pigmented, it's a white stripe. The lesion is located on the second finger of the right hand, and you have few seconds to examine the dermoscopical features. Let's comment on this case. We have a sharp demarcation of the lesion and a very sharp limit between the lesion, the involved part of the nail plate, and the uninvolved part of the nail plate. Moreover, we see that the edges of the lesion are very parallel and very regular. Some splinter hemorrhages are present, and everything here is in favor of an epithelial tumor of the nail matrix. Since the lesion is very regular in its shape and very parallel in its border, it's more in favor of a benign lesion, and we propose the diagnosis of Onychomatricoma. Onychomatricoma is a benign rare tumor of the nail matrix, and histopathology of this lesion confirm that diagnosis. I thank you for your attention, and I will see you again for next podcast. Goodbye.